Now this is the third question. I think Dr. Surya, she wanted to take it up.
Yes, ma'am.
Yeah.
33-year-old woman with her 40-year-old partner are being investigated for secondary infertility. The woman gives a 6 months history of amenorrhea. She has suffered 2 first trimester miscarriage in the past 5 years, requiring surgical evacuation of retained products of conception on both occasions. Her BMI is 21 kilogram per meter square, and all endocrine investigations are normal. Semen analysis are also normal. FSH and LH normal. Estradiol 220 picomoles. Choose the single most appropriate next investigation. So it's a case of secondary infertility with 6 months amenorrhea. She has suffered 2 first trimester miscarriage in the past 5 years. Wherein surgical evacuation has been done in the past. BMI is okay. Endocrine investigation is okay. Semen okay. FSH normal. Estradiol. Choose the single most appropriate next investigation.
Hysteroscopy.
Okay. What are you suspecting? Kindly explain.
Asherman syndrome.
Okay. Fine.
Yeah, no, this. Okay, hysteroscopy.
Fine. So J is the answer?
Ma'am, actually, we want to know about her ovulation status.
Please be a bit louder. Difficult to hear. Just be a bit louder.
Okay.
Wait, Dr. Hassan. Let her complete. Then everybody can answer.
Okay.
Ma'am, she's having secondary amenorrhea. So we want to know about exact ovulation status. Why can't we do progesterone challenge test one?
Okay.
Progesterone challenge test does not tell about ovulation, no? It'll just tell if she's responding and bleeding after progesterone is stopped.
See, always you have to answer the point which makes a difference in your management, right? Does progesterone challenge test, FSH, LH, MRI, hysteroscopy, what will make you define your management? Her endocrine investigations are normal.
Yes, ma'am.
So endocrine investigations normal, FSH, LH normal. If she is not ovulating, then PCOS. There is nothing else, na? It can be only PCOS, where FSH, LH is normal, means group 2 and ovulation, which is largely 85% PCOS.
Yes.
Yes, ma'am.
So are we dealing with the scenario of PCOS?
My other findings are actually not in keeping to PCOS, but she has been amenorrheic, just like the way Dr. Listen was explaining initially. So me, I was actually thinking for us to actually repeat even though the FSH and the LH was done, initially I was actually thinking maybe we need to repeat so that we can categorize her in which class she belongs to. But I saw the FSH and Enrol has already been done, so it's just confusing to me.
Dr. Surya, you want to add something?
Actually, I got confused between two options.
Hmm.
Whether to go for hysteroscopy or free androgen index.
Okay, fine. So we are going to clear this confusion. That is why I'm asking everybody for the option so that we can rule out all confusions. Right? So you are confused between A and J.
Yes,
Okay.
ma'am. Yes, ma'am.
Okay. Now anybody would like to comment on with what option you want to go and what is your opinion? I need explanation with your answer.
Ma'am, if they're writing all endocrine investigations are normal, then what we should assume? Which endocrine investigations they're talking about?
Usually you can just talk about the FSH, LH, maybe
That
thyroid.
they are mentioned separately also,
Yes,
ma'am.
that is not mentioned. So that is actually, you understand from that only.
So
That
then free
it
androgen
does
index
not
will
have
not
much
be.
significance in this. This is actually when we say that the question is not complete. So
No, ma'am. What
actually
I'm
the
asking
question
is,
is complete. That is not required here.
yeah,
No?
because then the free androgen index, ma'am, we can assume that it was done, na, because it is also a type of endocrine investigation, ma'am.
Okay, fine. Then what?
Why can't we go for a hysterosalpingogram? If
This
Okay.
is like Asherman's only. They're trying to point out towards Asherman's.
Asherman's plus tubal patency also we can test. So why not HSG?
Okay.
Tubal patency
So your
because she's
answer
already
is L.
twice, ma'am.
Hmm?
She's pregnant,
Ma'am,
right? But if she had two interventions. She could have some infection. She can have tubal obstruction post that.
Okay. So
but
your
ma'am, I'm not sure
answer is
whether the
HSG.
estradiol level.
Okay, so HSG, free androgen index, repeat FSH-LH, progesterone challenge. Now what?
Because
Ma'am,
they're
I'm not
mentioning
sure whether
first
the
trimester
estradiol
miscarriage,
level
ma'am.
is actually normal. I can't remember the value. So the estradiol is 220. So I can't remember the value range. So I was
Okay.
actually looking at it initially.
Okay,
So
wait. Now let's look at it. Lot of confusion has been created. I never thought of so many options actually.
Ma'am, because they have
But
yes, ma'am.
mentioned,
see,
ma'am,
remember, yeah.
they have mentioned that there was twice she has undergone surgical evacuation for latent products. So it is possible that they are indicating towards Asherman by writing that finding.
I agree.
And ma'am,
I'm denying it.
ultrasound is not an option here, or we could look into that also.
Hmm. Okay.
And it's not a recurrent
What I
miscarriage.
explained in subfertility live session that for Asherman, what investigation you will choose?
Hysteroscopy.
Then why are you thinking twice, thrice, four times? Clearly, you remember we talked in a table that what investigations to choose when? Simply when your question is pointing towards Asherman's, why are you thinking of other options? Simply when we have framed a rule that whenever Asherman's is going to come, we will answer hysteroscopy. This rule was framed in the class? Yes or no? Those who have attended live session, yes or no?
Yes, ma'am.
Yes, ma'am.
Yes?
Yes, ma'am.
So this is
Yes,
how
ma'am.
we get confused in exams. We have to stick to our rules in spite of lot of distractors. So these, whatever PCOS, this and that, whatever you are thinking are distractors. The basic rule remains the same. You first, when you started reading a question, first impression which came to your mind was the question is Asherman's. Right or wrong?
Yes.
Right.
Yes, ma'am.
When you start thinking about it, okay, I can give progesterone challenge too. But progesterone challenge can't make a difference. If this is a Asherman's, Patient is not going to bleed, and progesterone challenge will not give you a clear indication whether she is ovulating or not. Right? No sense. For ovulation, we do serum progesterone. Why we are thinking about progesterone challenge, right? So we have to stick to our basic rules. You have to find in question which is the basic rule which applies here. So once you start reading the question, she is a secondary amenorrhea. She has 2 times surgical evacuation. So largely it goes in favor of Asherman's. Now, what are the other things which are not in favor of PCOS? BMI 21. Fine. You can say that there are lean PCOS as well, but usually PCOS is more related to obesity. FSH and LH is normal. Usually in exam scenarios where they want to point out, they give you LH slightly high.
Yes.
Right?
Yes.
They haven't given you any hirsutism, any features like that which point towards the PCOS or any history of irregular periods in her past. Nothing. Right? There has been amenorrhea after these 2 surgical evacuations. So what is the more liable? It can be either it is PCOS or it is Asherman's. Which one has more chances? Looking at this scenario.
Asherman syndrome.
Asherman's. And for Asherman's, our rule is gold standard is go and do hysteroscopy. Yes, that is the question. One line question. It is one line question. Rest all is completely distraction. And the one person who can take out that one line and go simply with your answer can easily do all EMQs. And those who are going to analyze each and every word and try to fix each and every option there, then I think 4 or 5 options will be correct in EMQ. Right? Everybody knows that for Asherman's, hysteroscopy is gold standard. Everybody knew that. Right or wrong? Everybody knew it.
Yes, ma'am.
So we have to keep our confusions, our distractions on one side and focus on one basic rule. Right? So the answer to this question is hysteroscopy. And this is why this is the answer, because this line, 2 surgical evacuations, is in favor of Asherman's syndrome. Right? And we have read that whenever we will have Asherman's in a scenario, the investigation we are going to choose is hysteroscopy. So this is what we are going to follow here. Hysteroscopy remains the gold standard investigation for Asherman syndrome. No HSG, no ultrasound, no MRI, nothing. Now, if in this scenario, do you need to know about the endocrine investigations? No.
No.
You may say that the question does not mention in detail what are the endocrine investigations they have done. Maybe they have done androgen, maybe they have done this or that. But that is not required. That information is not required. That is only required if you are going out of the way of question. Right? So question is not incomplete. Question is perfect. You don't require the details of that information for answering your question. Got it? Any
Yes, ma'am.
confusion? Anyone?
Yes. Norma is clear, Norma.
Okay. Dr. Hassan, it's your turn now.
Norma, I'm well satisfied. I'm okay now.
You said I will answer. Now what?
Ma?
Do you want to take it or not?
No, I've already taken it, ma.
Okay. So
Yes.
next volunteer. Don't be afraid of making mistakes here. This is the right platform to make mistakes. You will remember things in exam. So
Can I
don't
do
be...
Okay, I should
Yes.
take the next question.
Okay. So this one
Okay.
for whom?
Okay, so let me take it, ma'am.
Yes.
A 20-year-old woman presents with 18-month history of amenorrhea, fatigue, and intermittent headache. She is otherwise fit and healthy. FSH 8, LH 4, prolactin 600. Choose the single most appropriate next investigation. Okay, prolactin 600. My will go for thyroid function test. Sorry.
Don't look at answers in the chat box. Answer with your own knowledge, right? Not really
Yes,
what
ma'am.
everybody is answering can be right or wrong. So answer what you
Now,
know, for
thyroid
what you
function
have
testing.
explanation.
Since the patient is having
Just
headache,
wait, let
there
him
is
finish, then I'm coming to everybody, right? Just wait. Yes.
18-month history of so the
Yes.
ma'am, 18-month history of ammonia fatigue, intermittent headache. Yeah. The prolactin level, I think is less than 1,000, so is normal. FSH is, so I would like to go for. I will still do the thyroid function test, ma.
Okay, fine. Got it.
Yes, for me.
Now,
Yes, ma'am.
everybody who is answering B or whatever, you can give your explanations.
Since a patient is having history of headache, it is suggestive of pituitary adenoma with this prolactin value.
Okay. Okay. So you want to go with MRI, right? Anything else?
I think it is D. Because
Okay.
hypothyroidism will lead to
Even
high
the hypothyroidism.
prolactin.
Even
Ma'am,
hypothyroidism.
ma'am,
A raised TSH will also stimulate the prolactin receptors.
Yes.
So we have to first rule out TFT, do a TFT, because a raised TSH, because of the similarity in their receptors, will act on those also and may lead to these symptoms. So before we directly go for MRI pituitary, which is a what do you say, expensive investigation, we should do a TSH first.
Okay.
अजहर शेगी वाला होगा ले लेना जरा.
Please,
But
please, mute
ध्यान
those
से दे दो.
talking. Like they can mute themselves. Yes.
But in the question, ma'am, they have pointed it out a positive history of intermittent headache with 18 months of amenorrhea. So the most probable investigation will be first is MRI pituitary, ma'am.
Okay.
If there is no history of headache with fatigue, only the raise of prolactin with amenorrhea, then we can go for a thyroid function test.
Okay. Okay.
Ma'am, can we do MRI with prolactin of 600, ma'am? Is it not like about 1,000? We can go for MRI or suspect any tumor.
Okay.
It's only
Fine.
just 600. It's
Yes.
normal only, now, ma'am. Just above the borderline.
Yes. Okay. Fine. Dr. Madhya, you want to say something? You also raised hand.
Yes, I want to see my answer is D because fatigue is maybe symptom of hypothyroidism and this is
Hypothyroidism.
prolactin rise due to hypothyroidism, which will lead to headache. Thank you.
Okay, great. Okay. So now basically we have confusion between the two things, MRI and thyroid function test, right? So these are the two things. Now, what is the most commonest cause of hyperprolactinemia?
Drugs
Great.
are the most
It's
commonest.
hypothyroidism. Drugs for the hypothyroidism.
Hypothyroidism is, yes, the most commonest cause
Drug-related.
is hypothyroidism. So let's look at the rules. What does the rules say? Serum prolactin less than 1,000, you have to exclude causes such as stress, recent breast examination, drug induced. So the ones who were saying that 1,000 is the cutoff were exactly right. If it is below 1,000, it could be related to some other causes, out of which hypothyroidism is one of those, right? So therefore, first going for thyroid function test at this value is important. So below 1000, we can't directly think about the prolactinoma. Prolactinoma has a more chance if it is above 1000, right?
1000.
Although with PCOS picture, up to 2500 prolactin can be there, right? With the PCOS picture. So if your question is rightly showing everything about the PCOS, then also you choose CT-MRI with a pinch of salt. But if there is, like in this case, there is no picture of any PCOS or something like that, you largely have to rely your answer on the prolactin values. So here, if it is below 1000, then thyroid function test is the correct answer.
But
Fatigue
she's
is the key word. I'm coming to your word, whatever headache you are getting confused. I'm coming to that. So fatigue is a keyword for thyroid problems, right? Fatigue is there, which is pointing towards the thyroid. Prolactin 600, which needs reassurance. We need to reassess, retest, or rule out other associated causes, which could have led to this value. Now coming to intermittent headaches. So are the headaches always related to prolactinoma? There could be multiple other causes of headaches, right? There could be multiple causes of headache. Not necessarily the headache is just related. See, if prolactin is not given here and it is only given as amenorrhea, fatigue, and intermittent headaches, then you can say that I would like to think about doing prolactin levels because headache is there. But they have already gone a step beyond that. They have already given you the prolactin. Where do we choose from the headache prolactin? When we say that scenario of amenorrhea, headache is